Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Welcome back, Turd Nerds. We have another excellent topic for you because we only do excellent topics here at the Turd Nerds. Yeah. But this one has been a topic that we've been talking about a lot recently. We've been getting a lot of patients with this topic, and it is diverticulitis.
Or osis.
So we'll cover what the difference is.
Right. I think
itis is the more problematic.
Yeah. The patients are walking into your office with osis, and you might not even know it.
That's right.
Once they hit itis, you know it.
You know it.
And they know
Everyone knows it. Yes. So let's dive in.
So let's do this in kind of two parts. The first part is what would happen if you went into your standard conventional doc's office? What treatment are they likely to give you? What treatment should they be giving you? And then from there, what can you do from a naturopathic perspective or functional medicine perspective? And then prevention. So why don't we do that?
Yep.
Yeah. So, for years, what we did with diverticulitis, if you thought someone had diverticulitis, which is, standard left lower quadrant pain, systemically not really feeling well, they may or may not have a fever. I remember one of the great senior doctors when I started in urgent care about 13 years ago, I was like, do I need a CT? Do I not need a CT? And of course, everyone gives you a different opinion. So generally what we would do is if they had a history of diverticulitis for one, we felt comfortable just treating them as long as they didn't have acute abdomen and didn't look toxic and had, stable vital signs, no signs of sepsis or anything like that. We would often just treat them with antibiotics and like an easy to digest diet. And that worked pretty well. If they just looked sick, their vitals were not stable, they did not have a history of diverticulitis, I'm generally more apt to send them in for a CT. If I have a colonoscopy report that says they had diverticulosis, then that would support. But again, If they're acutely ill, they probably need, they need a CT to make sure they don't have an abscess or a complicated diverticulitis, right, as opposed to kind of a standard like, oh, I've had this before, my doctor gave me antibiotics, I got better. You have to kind of decide who is appropriate for outpatient versus inpatient, or at least imaging. And the standard was, for outpatient management for the standard patient who has a history of this and does not look super ill and is stable, was to give antibiotics. And then I recently was looking this up just to confirm I still was giving the right antibiotics. And I was kind of surprised. I don't know when it happened, but there's been a change in the up-to-date recommendations of not giving antibiotics routinely, which was surprising to me.
Yeah.
Because I don't know that I had heard of a particular shift in sort of standard of care for this. They don't say you can't give it, but it's for the generally stable outpatient patient. They're recommending generally pain control and a liquid diet initially,
yep,
and then kind of deciding. And so generally what I've been doing is I potentially still will give the antibiotic prescription, but give them the initial recommendations, check in with them if you can, or at least have them know, you can start this if things aren't turning around, go to the hospital if you're getting worse.
So right. One of the tricks that I've been taught, because I'm mainly in the ambulatory care outpatient setting, well, not mainly, exclusively. I'm exclusively in the
except for when you moonlight at
because they really need naturopaths in the emergency room. So the rule of thumb is always put them on a liquid diet for 24 hours. Liquid diet means no sugar. These are really just clears.
Like, you've always done this.
My answer is I don't know.
Right.
I don't know if I've always done it.
Right.
This is what my brain brings up now.
Right.
But if you put them on a liquid diet after 24 hours, this is not smoothies, these are not fibers,
Broth.
these are not
Clear liquids.
broths, clear liquid.
Kind of like
And
a
not-
colonoscopy prep diet, but without
Yeah,
the gross.
Not an elemental.
Not an elemental
because
diet.
that has a lot of sugar.
Exactly.
Yep.
Clear diets. And if they're not having some kind of improvement in their symptoms at the 24-hour mark, most likely it's not a diverticulitis flare. That, generally speaking, not 100% because it's still medicine, generally speaking, if they are not eating anything, which, by the way, to these patients is kind of a relief because they are so uncomfortable.
Yeah.
Like, it is a lot. I remember my mom was having a diverticular flare. It's so uncomfortable.
Yeah.
If they're not responding to all clears at the 24-hour mark, you're treating the wrong thing.
And can we just go over it? Because patients will ask specifically what to eat and consume.
Right.
And so
Yeah.
we're talking about like broth and Jello.
Yep.
Broth, Jello,
Water.
Okay.
Yep.
Okay. So
That's
just
pretty
so we're
much it.
being clear.
Super boring.
Yep.
So do that for 24 hours,
24
see what
hours,
happens.
You are expecting an improvement in their symptoms.
Not resolution necessarily,
they
just
have
moving in the right direction.
If they have
Drastically.
uncomplicated
If they have
diverticulitis.
uncomplicated diverticulitis, obviously if they're febrile,
Right.
if their pain is intolerable, if they can't deal with it, if their vital signs are not
Yeah.
stable,
Yeah.
this is a go to the hospital. Like, you don't need to do all clears. Let them
Right.
deal with it.
What about blood?
I don't see a lot of blood in this diverticulitis. Do you?
It can be. You can have elevated calprotectin. You can have blood in the stool. And in those cases,
protection is there because the pockets are inflamed.
Yep.
The white blood cells are
frank
dealing with the
inflammation. Yep. And the blood can happen. And my question has always been, is that like more emergent? Do you need the antibiotics in those cases or?
So that's a great, my answer is I've never seen that clinically.
Yeah.
So I don't know. That just happens to be I just haven't seen it.
Yeah.
I can remember back in the early days when Dr. Kapadia and I worked together when she was just starting at my clinic with me, and I put a patient on antibiotics, and she looked at me and her face looked confused, and she was like, the antibiotic that I chose was not the right
I remember
antibiotic.
that too.
Yeah.
It wasn't fully wrong. It just didn't have both components. And it wasn't you were guiding someone else on it.
I think it was me.
No, it wasn't you.
Okay.
It was someone,
but
we'll pin it on someone else.
There are antibiotics that we prefer.
Right.
Can you explain that?
Yeah, so basically we used to often do, let me just confirm I'm giving you the right information, but we used to pretty typically do Cipro and Flagyl, right? That was standard what I learned. Is that what you all learned?
That should take care of it.
But, we don't love to give ciprofloxacin anymore. So an alternative is Augmentin. And I believe the person you were guiding used amoxicillin. So it's not like it was totally off base, but it had not been something I had used. And I don't know that Augmentin was one of the options at that time, but it is now. So I mean, if it was me, I'd prefer to take Augmentin than Cipro and metronidazole.
For sure. Go ahead.
Yeah, the other option is Bactrim and metronidazole, which would also be preferable to ciprofloxacin. And then levofloxacin and metronidazole, which again we have similar concerns with that class of medicine. So,
and the concerns basically are ruptured ligaments, and it's really, really hard on the connective tissue.
Yeah.
According to Up to Date, in approximately 50% of cases of diverticulitis, there's bleeding.
Oh wow!
This is what it says: diverticular bleeding occurs when a small artery located within the diverticulum is eroded.
That's bad.
Either due to the inflammation or whatever else is pooling in there.
Yeah,
but that's a lot.
That's a lot. I've never seen it. It's amazing because I've seen a lot of diverticulitis.
Yeah, and we all ask. There's blood in there.
I've seen it as a decision aid in whether
that was my question.
To be more acutely triaged versus treated outpatient.
I would imagine if there's an artery bleeding, the risk of sepsis would go up.
I would imagine
that would make me a little more concerned.
I'm with you on it.
That being said, if they said it's in 50% of cases, I don't think we send 50% of people who come in with it for imaging. Again, I think it depends if they have a history of it and
what else is going on.
Vital signs are and all the things.
Exam. I know we're going to get to prevention here, but if you're going to be giving any of those antibiotics, would you, from a more naturopathic lens, also be giving sacroiliity?
I give sacroiliity in my
quite
sleep.
Loosely.
Like in my sleep, somebody said, "I have pain." Sacroiliity.
Yeah.
But always with antibiotics.
Yeah.
Like any of my patients who end up on antibiotics and don't take sacroiliity, I realize that I'm a failure as a clinician because that is my favorite soapbox.
Yep.
I give it as long as they don't have a concern for any kind of a yeast allergy. I just put it on with when I remember, I have a quick phrase for it to just take it with the antibiotic.
Yeah,
right?
Exactly. And it is okay to take with antibiotics, unlike other probiotics.
Which
Like,
you can take, though. This
just
is
away,
money.
just
Just a waste of
away from it.
money. So that is, I think, standard. And then if treatment fails, I definitely have a subset of patients who get the diverticulitis again and again and again, and we end up referring them for surgery to resect that part of the intestine.
Yeah.
That is something that I've seen. I don't love to do it. I mean, nobody really wants to do a bowel resection.
Yep.
The surgeons don't want to do it. There's like such a risk of 1,000 things. But if people are getting these diverticular flares that are severe, I mean, these people are in severe pain. Surgery is our next option.
Yeah.
Right, because I don't know that there's any data on reversing diverticulosis. And if that's possible, doesn't seem like
I think
it would be
once you
possible.
lose the compliance and the tone, it's out. But I think it's worth there are sort of like two tiers of diverticulosis and then into itis. It's like you just have the problem that might get infected, and then you have the complications. And we talked about sepsis, but you can also get fistulas, obstruction, abscesses, and then of course if it leaks into the blood, like that, those we need to know, is the person doing that or not, because that definitely changes treatment.
And, for those people who are getting these flares again and again, that's when our prevention strategies, which we'll talk about in the end, become worth their weight in gold. And that is like, I think a lot of my education with my diverticular patients are, okay, how do we treat the acute? And then what are we looking for to know that you might be starting that step ladder to get back into the acute when you're in the chronic? And those people have to be obsessed with the prevention. Besides that,
it's worth it though.
It's worth it though.
I think what I was reading is a quarter of people end up with these complications. So it's good for us to know in terms of monitoring people, but also, let's not have our patients be one of those 25% of people.
So, we can talk about some quick post-surgery supports. Just if you're so severe and the antibiotics fail and then we go into surgery, then, whenever I have people go through surgery, I'm always trying to get them as nutrient dense as possible, using either IVs or using high dose nutrients before and after
for healing.
Just, with vitamins and minerals, you're just thinking about it as like, these are the enzymes, like it is the nutrients that become the enzymes that make the 1,000 processes in the body work. And so you want to make sure they have a ton of nutrients because they're going to need even more processes because they just got a piece of them cut out. And then for mucosal support, don't forget about our favorites, glutamine, zinc carnosine, and then herbal anti-inflammatories.
Totally. And all my patients who get pelvic or abdominal surgeries, I'm getting in for abdominal therapy after to get better circulation and hopefully prevent any scarring, because that can happen with any incision, but also with inflammation. Infections can also cause that internal scarring.
So there was this really, really crazy data set that I found that was looking at endometrius scarring, adhesions that occur post endometrium resectioning surgery. And they found N-acetylcysteine at 600 milligrams 3 times a day decreased the amount of adhesion formation.
NAC is like a no-brainer for endometriosis. Like, go back and listen to our endometriosis episodes, but it decreases the lesions. It helps with the healing. It helps with ovulation if that's important to people. Like, no-brainer.
It's a no-brainer for post-surgery or in general?
In general for endo, but definitely at any stage of treatment for people.
I do tell patients, I am extrapolating because I don't have these surgeries. I don't have this data for post-diverticulitis surgery, but I am just now stock any abdominal surgery my patient is going through. They're on NAC 3 times a day post-surgically.
How long do you keep them on it?
I usually go a month.
Yeah.
Great. A bottle usually has 90 pills.
That's right.
Yes, that sounds
Make it easy. And then real quick, why are we talking about CTs instead of colonoscopies for these folks?
Well, they need a colonoscopy if it's their first bout, but you have to wait a while.
Exactly.
So I think it's 6 to 8 weeks or something. But
because of the perforation risk with inflamed tissue. Gotta let it heal.
Acutely you get the CT to see if there's complications if you're worried about that.
And make sure you're treating the right thing.
CT scan?
When in doubt, just CT. One of the most common conversations that I have with patients is, I work with an inflammatory cerebral bowel disease population, and they always want to do a CTE. And I'm always like, can you ask your gastro about an MRE? Let's just do an MR instead of a CT. Let's just get you way less radiation.
They want to do a CTE instead of a colonoscopy?
No, they want to do a CTE when it's not time for the colonoscopy yet. Just for monitoring, But my IBD patients, like most of them, if they're well controlled, they're not seeing me. You know what I mean? Like it's the people who are poorly controlled that are looking for other options, right? Or the people who are really afraid of drugs.
Yep.
But if these people are poorly controlled, then all of a sudden they're getting significantly more imaging than what we know is recommended.
So are CTEs done relatively regularly for patients that are uncontrolled if they're not due?
Every time something goes wrong,
Yeah.
and they don't know what it is, they do another CTE for monitoring.
Can we talk about why this happens?
Why? What happens?
Diverticulitis, diverticulosis.
Back to the topic.
Why does that happen? Yeah. Okay. Well, it happens equally in.
Sorry, can we just clarify what happened in the room? Dr. Sand said something.
I know.
And both Ami and me looked blank and nodded our heads.
I know, but I think it's important
related to our diet in some way.
Well, it happens more in more modern developed cultures.
Like
so
IBD.
There's a lot we can unpack there. It's equal across genders. So, I think we think of it, I always thought of it as like older white males was sort of the population that maybe gets diagnosed.
Population everybody researches.
Yeah, exactly. Better diagnoses? I don't know. But I think about it a lot with chronic bowel issues, chronic constipation. I see it with chronic diarrhea, which I'm not really sure why that is, because I think of like outpouching, lack of compliance, atonic constipation predisposes you to that. But I also think people with, this is my theory, I think people with chronic diarrhea spend more time on the toilet.
Yeah. Just like,
and we get that pressure. Exactly. So so I think, we'll get to more prevention strategies, but even in acute situations, helping people with just structural support is really important, getting things flowing. Squatty potty. That's the point of what I'm saying. Get us prevent that. Okay, are we out of acute situation? Anything else?
Let's talk about what we can do herbally in the acute.
Okay, yeah, great.
Let's talk about herbally in the acute. So, the liquid clears are a no-brainer. Either way, you have to do that.
Yep.
When I have patients on the liquid clears, I am a naturopath. I will start herbs. And I generally, when I'm dosing herbs for these acute patients, so one of the things that I do is if I have a patient walk in who's a new patient who has a history of getting diverticular flares, I will just get them a prescription for either teas or tinctures right away.
Mm-hmm.
So they have it.
Yep.
And it says diverticulitis. So then I'm training them to remember to start the clears right away.
Yep.
And then also start the herbs right away.
Love it.
I'm obviously going to give them tinctures or teas over pills because they need to be drinking the clears either way. So tinctures a no-brainer. There are lots of herbs that we use anecdotally for diverticulitis. There are herbs like the mucilaginous herbs, symphytum, achillea, linenum. I can't remember the common name for that one. But those are like going to coat up the tissue and heal it.
Yep.
Then there is a bunch of the antimicrobial herbs like echinacea, mahonia, propolis, glycyrrhiza.
Yep.
And then there's the carminative herbs that we can play around with. Fennel, turmeric, ginger,
peppermint.
Yeah, all the carminatives. And so what I'll usually do is I'll put together, depending on where they are, either a bulk tea that they can boil and it's going to have a lot of these roots in it. So it's going to be boiled like a decoction for a long time.
Yep.
Or if I can get them a tincture, and my access to tinctures just went down pretty significantly.
Yeah.
But so either a tea or a tincture, and that's what they start to drink to deal with the tissue.
Totally.
Turmeric is a really, really good friend here.
Yeah.
Mainly because there's so much inflammation that's happening with that diverticular pocket. Turmeric, I often question. We talk about turmeric in the functional medicine naturopathic world all the time. And I'm always like, are we talking about it so much because there is this like research momentum? Like turmeric was shown to be effective for these conditions. And so all of a sudden we're just like studying more turmeric. Can turmeric do this? And we're probably missing a lot of herbs. But then turmeric also comes up in both Ayurvedic and in Chinese medicine all the time.
Yep.
And I wonder if they could just buy like turmeric root and make a decoction.
That's what I would do.
Yeah.
I just say the more the merrier. Yeah. Like, especially in diet sources, you're not going to overdo it on turmeric. Just turn your poop yellow.
Yeah.
You're doing great.
But I don't think you could use like a dried, like you'd want like a fresh turmeric, right?
Or dry. No, I think you can decoct with dry.
Really?
Yeah, absolutely.
And teas, have dried root that you can brew with a little ginger. It's delicious.
One of my favorite herbal prescriptions that I use for diverticulitis or losis, as well as other things, is what I call my anti-inflammatory chai. So it's like turmeric, clove, star anise, cinnamon, ginger,
it's like golden chai.
Pepper. Yeah.
Yeah.
But like with all these other really good licorice. Like,
you have them do a water base, or when can they add milk?
No milk. Wait, what's the question? Not for diverticulitis. For
When in their
diverticulitis,
healing,
no
it's
milk.
better. My question is, it's better with milk.
Because it tastes
And
better or because it works better?
no, it
Oh,
tastes better.
Not if
But
you're
doesn't
a
the
diverticulitis
fat,
flare.
for sure. So after like 3 days, if you're getting traction and you're starting to expand food, doesn't the milk extract different constituents? Yeah. Yeah.
Because the fat in the milk is
Yep.
what's able to hold some of those constituents.
Yeah.
Absolutely.
And it's just better.
But if you're in a diverticulitis flare, I promise you food is not appealing.
Yep. And milk is not going to be good. Blah.
But does milk take? Yes, there's a reason why the entire country of India makes these incredible milky chais.
That's right.
Because they're delicious.
That's right. So maybe give it a couple days of just the herbal one. It'll feel better.
Yep. And then the other thing that I always talk to people about is even when you're in acute flare, adding in some probiotics.
Mm-hmm.
You can add in prebiotics. We're going to have a conversation about prebiotics.
Yep.
We're talking about
yes,
prevention.
we sure are.
But you definitely should be adding some of the probiotic nutrients.
What do you choose?
I usually will go with some kind of multi-strain class 1.
Yeah.
So a lactobacillus bifido multi-strain.
Yep. And do you have people open it or just do the capsule or powder? Yep. Sprinkle it in something. Take it. Yep.
No capsules. You're 100% only.
And they make powders. You can add to stuff. So whatever works. Yeah. And then start slowly, ramp it up, or do you just hit them hard?
Well, they're so uncomfortable.
Yeah.
So it's like as we're coming out, like as they're starting to get better after a day or two, then I'll start with some probiotics, and then we'll try to introduce food back in, and then we have a conversation about prevention.
Yeah.
Anything else for treatment before we jump to prevention?
I don't think so.
For the probiotics, what I've been doing lately for all things is asking people how they do with them first before I give dosing recommendations. And that has really helped me out. If people love them and they do better, I dose them high to begin with. They're fine. If they've had bad experiences for whatever reason, we open the capsule, we go very gently. It seems to work better that way.
Yeah.
But I would maybe consider if people, because we don't know, do they also have SIBO? In which case that might not go so well for them. And just be gentle. But
I guess I have a clarifying question about the mucilaginous herbs. You gave all the names that I don't know. So are you talking about like slippery elm?
Marshmallow,
aloe.
Okay.
And then Achillea
someone should come up with a diverticulitis tincture.
So there
you guys
was
should do that.
a great diverticulitis tincture that was put out by Dr. Yurnell.
Okay.
But he pulled it off the market.
Huh.
I just called Dr. Day, who is now one of the owners of Heron Botanicals, to say,
why?
No, do you still have this formula? And he was like, no, we pulled it off the market.
Oh,
weird.
It wasn't moving.
There's enough diverticulitis. You have to let people know it exists.
When you need it, you really need it.
Yeah.
Totally.
And
It's not
besides that, you
cute.
don't really need it.
True.
Yeah.
So that's treatment, both conventional and naturopathic. Let's talk about prevention, because really the majority of the conversation you need to be having with your patients is prevention based.
Yep, totally.
The first thing in my experience is they cannot get constipated.
Yep.
Whatever you do, you need to prevent constipation.
For 2 reasons. One, it's going to worsen the outpouchings. So it's just going to set them up for more problems.
Yeah.
But 2, things brew. When we have stool retained in the colon, it ferments and we just get pools of bacteria, and we can't let that happen to these
I
folks.
just imagine this witch over her cauldron, like in your intestine going,
Yeah.
while she's brewing this infection.
It smells, what did you say? Putrid? Putrid. That's the word. Gross.
And so, one, they have to prevent constipation.
Yep.
Like that is kind of the conversation that I have is the minute you feel like you're getting backed up, the minute you push a cleanse to get it out.
Yep.
We know that when it sits there, it's going to get worse. You already have this weak point in your body.
They can't afford it.
You don't get constipated.
Yep. And we all know my favorite option for fiber and constipation and all things bowel.
Psyllium. Okay, can I just say, do you know how many times in the last 3 weeks I've told patients I have this perpetual fight with Dr. Sand about psyllium caps versus powder?
I think I'm just blessed. Right. I think I'm just blessed.
I also think I think you're right. I have not been getting the compliance that they're telling me I'm getting.
No one. I tell all my patients, I used to give them an option. I used to give people an option. If you want to do the powder or the capsules, no one took the powder.
Yep.
So I don't even ask anymore. You take the capsules. It's a lot of capsules. We know that, but it's gross and you're welcome.
So now I am giving people capsules. Yep. Thank you, Dr. Sand.
You're giving them powder.
No, I think that she's right. I think that they were not taking. They were not.
You give capsules, or you give capsules.
I think there's benefit, like Triphala and like all these other herbs, to having the taste in the mouth and the bitter and the gross and the upper digestive tract. Well, the problem with psyllium is no one takes it. So getting psyllium in is better than not,
and it works.
And it still works.
Yeah.
So anyway, I love psyllium with my whole heart. It's my best friend.
So there is obviously anything that we can do to prevent constipation. We've got more episodes on constipation than I think anybody out there.
Yeah, listen to those. We need fiber. We really, movement though, I think is essential. Like this pelvic stagnation, we talk about it all the time here. It really matters, but you've got to move, whether it's biking, squatting, yoga, Pilates, like whatever.
Have you guys seen the Blue Zones Netflix series? Oh, it's a good one. Have you seen it, Dr. Sand?
No.
Oh, okay.
It is a good one.
Yeah, it's a really good one.
Okay, I'll have to watch it.
for you. Itchy, like it's a little bit.
I haven't watched.
I
want to go to
learn
other places now.
It's a good plan. We should do that.
Oh, I've heard
Are
of
you
it.
interested?
Yeah.
I really want to go.
Yeah.
Okay. They said we can drink wine though. It's okay again now.
In moderation.
I'll drink the wine. I'll take it for the team.
I like flower nicely.
But that alcohol.
But they have special wine, Ilana.
Oh, it's magic wine.
It's like special. Yeah, seriously.
Oh my
it's like
goodness.
medicinal.
You
know me. I'll do anything for health.
I'll do anything for wine. So
let's go back to prevention.
But on the note of alcohol, super inflammatory to the bowels.
Super inflammatory to the bowels.
Unless it comes from this special place in Icarus.
Okay, except for this one.
That's still probably not during an acute fair.
I don't know.
Not during an acute
alcohol, fair. I mean, we drink so much in this country.
Our cultural relationship
is very skewed. Exactly.
To say, I lived in Scotland for a short Saturday.
It doesn't count.
Abroad there.
It doesn't count.
There. And you think the U.S. has an altered relationship. The entire point, I think, for me to be educated in Scotland was for them to get me pissed or drunk.
Yep.
That's what you say in the UK. We're going to get pissed. Oh. Like, every event had, like, free-flowing alcohol where everybody was getting shit-faced.
Yeah.
Like, we have a pathologic relationship to a lot of things. So do other countries.
Yeah. I think
that was not featured in the Blue Zone.
Neither was any place in the UK. I'm sure the UK was not featured there at all.
The thing that is a little bit different, though, and it doesn't maybe negate the effects of the quantity, is it's a social thing in other places. Here,
yes, I think that's a big part of it.
Pull up, isolate, and self-medicate.
Yeah, it's not used in.
And that's a really toxic combination.
Yeah. And that brings us back to diverticulitis.
That does, yeah. So
let's go back to so fiber, most important. Healthy exercise,
treat constipation, activity, movement,
and diarrhea. Get people off the toilet. Don't be on your phone on the toilet for so long. Quick bowel movements.
Is the solution to diverticulitis is psyllium?
Well,
in capsule form.
You know my opinion on this. You know, it's not going to hurt. Let's say go slowly, ramp it up, but it's a great addition for these folks.
Remind us how many caps. Of the one
I do a titration to bowel tolerance for people. So I start with 2 or 3 depending on how sensitive folks are, and then every couple days increase by 1. Just go really slowly. Make sure
3 times a day.
Bowel movements?
No,
capsules. I find it effective somewhere between 4 and 9 for most people. Caps in a day. And if you get past 4, do in divided doses away from other meds and supplements.
I will actually say I have stopped telling them to separate from other meds and supplements. Mainly because I am looking at psyllium as if it's a food.
Yeah, but it binds everything up.
I don't think it binds as well as other binders.
I would just try to get it in. No one's going to take things away from food more than once a day. So
yeah, exactly.
I would just do it once a day, whatever dose you're going to give.
Yeah, people do it. It's just, especially if you're ramping up, taking like 8 capsules of psyllium in one sitting is quite a bit. Yeah. But
I get a little nauseous.
Yeah, I can't do that. And then the only way it really backfires consistently is if people are dehydrated. That will stop you up.
Bloated,
which is our
constipated.
Yep.
Hydration is our pillar. Fiber is our pillar. Exercise is our pillar.
Yep.
Vitamin D actually is another big pillar.
Yes.
Lower vitamin D status does predispose to higher diverticulitis.
Yep. And infections in general. Yep.
And so make sure the vitamin D is optimized.
Yep.
I will say I do have this like crazy subset of patients that I cannot get their vitamin D up no matter what I do.
Do you do injections?
I just started doing injections.
Okay. I'll be curious what you think of that.
You love doing injections.
That is true. But I literally have a subset of patients I could not move them.
Yeah. The compounded vitamin D injection?
I mean, through a sterile compounder. Yeah, there's no drug vitamin D yet. I'm sure it's coming. And I'm sure they'll make it way too strong. So, yeah, I'm just doing injections.
And is that working when the oral didn't work?
Yes. Yes, because it's bypassing their GI.
Yeah, totally.
Like anybody who has diarrhea because they can't absorb fats.
Yeah.
I mean, with your population, it makes sense.
Totally true.
Okay, and then other things to think about is mucosal support.
Yep.
You know, probiotics.
After the fact, yep.
Yep, making sure that the mucosa is as strong as it possibly could be.
I'm running a lot, like if there's anything else going on, which usually there is, testing to just get a read on the microbiome for these folks.
And
like
treating what you find.
Because everything, as we talk about always, is some symptom of a dysbiotic gut.
Yep.
If you're tipping into infections, especially recurrently for folks, what else is going on? How can we build more resilience in the landscape?
Yes.
And I think, even small bowel issues, it's upstream from the
Yes.
colon. It can throw things off. So correcting that, I
For
think, is a
sure.
huge, important piece of this.
Which is why extra is important.
Yep.
Like I tell everybody, my new religion is orange therapy. I go to I love it. Yeah, I went this morning. It makes me happy. But what I'm noticing is every time I'm working out, either doing the cardio or lifting weights, I start belching. Which I'm not a belcher. But I think my intestines are moving.
Yeah.
So they're moving things out. Like I generally, if I'm going to do something, I'm more likely to fart.
Yeah.
Which is why I don't eat gluten. You know what I mean? Like, it's not worth it for me to fart. I sit in a room with one other person. They all know where the gas is coming from.
So I do a ton of abdominal therapy in my practice. I'm in people's guts all the time. And I am very mechanically moving things through that their bodies just aren't able to get. We are meant to be
still
twisting
need to do a YouTube video on
and
that.
crunching. I mean,
we need to film.
Yeah.
We do. I know. But like, we're supposed to be moving our abdomens way more than we do in our culture. And the best I can do for a lot of folks is get my hands in there and physically move it. But that's exactly it. We're supposed to be getting that gas out.
Yeah.
We're supposed to be moving the bowel contents. Like, just sitting around and hoping for it doesn't work.
I thought it was, I was like trying to figure out if it was a thing, but I'm like, no, it's a thing.
Yep.
Every time.
Yeah. You got to think of wringing it out. Wring it out. Those yoga spinal twists.
Yeah.
Good stuff.
Weeding.
Yeah.
It was in the documentary series. They do a lot of like outside.
It's so therapeutic.
And they're not building raised beds. Like my raised beds.
And they don't have sofas.
Yeah.
Anything else that we're missing for the diverticular case?
Well, I mean, we didn't dive into all the sort of co-infections that can cause issues for people there, but we mentioned
We've done those before.
Yeah. Go back and listen to those episodes on things to have on your radar for it.
They're all the
The only other thing is I've had a couple of patients more recently that they know they go into a flare during times of high stress.
Oh, right.
So, don't forget that brain-gut connection and really, be thinking like with all of our chronic conditions that affect the bowels, what gets people into a flare, what gets people out, but the landscape's big on what tips people. So sleep, mental health support, job stress, moving your body. We need to have a discussion on all of that.
Okay, recap. Can I do the standard of care recap?
Sure.
Okay, so recap, the first thing you're going to do is put them on oral clears. If they're not getting better by 24 hours, you might consider to start antibiotics. But generally, I think oral clears, I'm going to do a minimum of 48 hours.
Mm-hmm.
And it's actually a relief to most patients.
Mm-hmm.
If you end up starting antibiotics, then you end up starting either Augmentin or a Cipro plus metronidazole.
Mm-hmm.
Or Bactrim plus metronidazole. So those are like the standard of care. Don't do what I did, which is start them on a penicillin-based drug, which doesn't really get there.
Yep. And add Sac-Boulardii.
And add Sac-Boulardii whenever you take antibiotics for the rest of your life with every condition. And
put it in the water.
So that's convention. Who wants to do naturopathic?
Well, in terms of in acute settings, we're going to be doing lots of liquids. We're going to be doing our herbs, our mucilaginous herbs, adding probiotics in powder form for folks, slowly reintroducing diet when people feel better. And then in terms of prevention, should we popcorn it?
Sure. So treat constipation, hydration, movement,
prebiotics,
high fiber,
treat any microbiome imbalances, vitamin D.
Move your body.
Support.
Don't sit on the toilet too long, people. You get pouches in the colon.
A sad note to end on.
I know. PSA though. PSA.
Dr. Sam.
All right.
Okay, guys, thanks so much.
Steroids.
That's good.
Anna, do you have?
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.